Well, good morning, everybody. It's an honor and pleasure to address the FDRS, and yeah, I'm a lifer, so I'm going to jump right into it. So I'm talking about weight loss. I'm going to go back. The talk is about weight loss and metabolism in lipedema, and also tissue biology, but it didn't fit in. I didn't fit well in the slide, so. All right, so I want to thank the Lipedema Foundation for supporting this research. It's very important to look at the fundamental markers in lipedema, and it was also done in collaboration with Washington University in St. Louis and St. Louis University. So in over 20 years, I've been working on lipedema, diagnosing and treating, and been publishing in research and manuscripts and book chapters. So my big principal role was in the diagnosis and recruitment for patients to be in this study, and so a little bit about how I've talked before about how to diagnose, but I believe in a very thorough diagnosis in including hands-on evaluation of the tissue for stemmers, edema, inspection, and as well as assessing mobility and biomechanics. I think that's obvious, and as well as the cuff signs. All those things are important for proper diagnosis. So let's talk about lipedema treatment in general, and that involves compression, diet and low refined carbohydrates, and I think it's critical that in this study focuses really on the diet intervention of a low refined carbohydrate diet, and it's really critical that we address this treatment comprehensively, and that includes exercise, supplements. We're using GLP-1 medications, use of pneumatic compression pump for some. MLD is also always important, and surgery has its role as well. So a little bit more about the surgery. So it can, I've looked at following biomarkers as well as outcomes, patient-reported outcomes. The surgery has an important role in terms of improving mobility and quality of life that I haven't seen with just the diet and compression. However, we're going to focus more on the diet and compression. But so I did publish a paper showing the improvements in mobility and quality of life, received in 2023 that received an award in 2024. So the first important thing about this study is because we used MRI and DEXA scan to characterize the adipose distribution in lipedema patients. And so we were able to, very objectively, numerically measure whether the fat is truly disproportionate in lipedema. And yes, it is. So compared to BMI-matched controls, the lipedema patients had a disproportionate accumulation of leg fat mass and then compared to obese matched and more than lean participants. So that's You could also look at this as well as confirming, I guess, that that if you define lipedema as a disproportionate accumulation of fat in the limbs, this also reconfirms that is indeed what lipedema is. And the next important question it asks is, can fat in the lipedema affected limbs be lost? Can you reduce that fat with weight loss? And this proves that when women with lipedema lose weight, they do lose weight in their lipedema affected limbs, specifically their leg fat. Does decrease about 10%. Again, this was, the patients had about a 9 to 10% weight loss, and they lost about 10% in their leg fat mass. So additionally, but what is very important is that the proportion of their leg fat did not change. So while they lost weight in their abdomen and leg, the proportion of their leg fat mass persisted even with weight loss. So also we looked at all sorts of metabolic factors in women with lipedema. And so we found that the lipedema women had increased insulin sensitivity. So this is the opposite of diabetes, that they were 48% more sensitive and this was studied with a hyperinsulinemic glucose clamp, which is the most sensitive way to really measure. It's real-time insulin and glucose levels in the plasma, and so the women with lipedema were 48% more sensitive to BMI-matched controls who didn't have lipedema. And I'm just going to point here that so if you look at a normal lean person, this is their insulin sensitivity, and this is in orange then is the obese BMI matched, and then right here is the lipedema. So they're in between, so compared to their BMI matched controls, they are more insulin sensitive. Now, we looked at other metabolic factors like lipids, cholesterol, triglycerides, and they were not statistically significant. So it really was just in the direct measurement of insulin sensitivity where women with lipedema were metabolically different. Additionally, with weight loss, the women with lipedema had further improvements in their insulin sensitivity, and it's not so. If you can see here, again, it improved quite significantly. And that they became closer to a normal lean person without lipedema, which is quite remarkable. So they benefited quite substantially from the weight loss in terms of their insulin sensitivity and that metabolic profile. We looked at tissue biology and specifically RNA assessments of gene regulation in the lipedema tissue, and is looking for differences between the thigh tissue of lipedema women versus BMI matched controls. And so in the thigh adipose tissue, there was an upregulation of endothelial cell differentiation and endothelial cell proliferation. And these are markers of fibrosis, and angiogenesis was also upregulated, as well as vascular development and blood vessel development. And this is kind of consistent with the, that lipedema is a fibrotic disease, and it is a vascular disease. Now, interestingly, fat cell biosynthesis was downregulated, and that is very interesting, as well as other carboxylic acid biosynthesis and fatty acid metabolism. So I think that's very interesting and may point towards possible pathogenic mechanisms as well. So very, very interesting in the tissue biology. So conclusions and significance of this research. So the fat in the lipedema areas can be lost with a I want to go in, I'm going to go back a little bit and talk about the diet specifically, because we talk about low refined carb, which as I mentioned, but it was very carefully controlled diet. So this diet was prepared in a metabolic lab at Washington University by registered dietitians that accounted for all of the macronutrients and micronutrients. And this diet then was a Mediterranean based, and we chose a Mediterranean based because it's one of the easiest diets for people to enjoy and be able to eat, and still have low in refined carbs. And so this was a very carefully, the patients were eating just what was prepared in these metabolic labs, and then eventually they had weekly diet coaching and nutrition coaching, and this type of low carb refined diet was associated with weight loss and fat loss in the diet in the lipedema affected areas. So now there's no cure for lipedema. So but this proves that that we can help the women with lipedema with diet, and so diet must be part of a comprehensive treatment. And treating lipedema solely surgically, in my mind, with this evidence and other studies showing the improvements with low refined carb diet, proves that you need to treat this comprehensively and not solely as a surgical disease. And so I believe that surgeons should ensure that dietary and other conservative measures are adopted first, before surgery and continued after surgery. So thank you for your attention. I appreciate the opportunity to present here, and I'm free for questions if I have a minute or two.
You have 1 minute for questions, and you are a very hot topic with lots of questions here. So the first question is, how do Ozempic and some of the others impact adipose tissue?
Well, that's a very exciting topic. I could talk for hours on that. So they do have, I believe they have a direct effect on adipose tissue, and there's some studies hinting at that. But the short answer is that is something that is unfolding, and we don't know. But there are some interesting studies showing that DPP-4, which is expressed in increased amount in lipedema tissue, and it is what degrades GLP-1s So that this may be one of the keys why they're so effective in lipedema tissue.